Here begins tape number 1 in the deposition of James Black III, MD, in the matter of Kevin Tolson versus St. Agnes Healthcare Incorporated et al. In the Circuit Court for Baltimore City. Case number 24C12008-071. Today's date is February 20th, 2014. The time is 2:22 p.m. Video operator today is Brian Mackey. This deposition is taking place at the offices of Pessing-Katz Law, 901 Delaney Valley Road, Towson, Maryland. Would counsel please identify themselves and state who they represent?
Rodney M. Gaston, and I represent Kevin Tolson, the plaintiff.
Mary Pat McGuire, I represent defendant St. Agnes Healthcare, Inc., and Caroline Stell are in.
Robert H. Bowles Jr. on behalf of Dr. Jackson and Quipta Shaw, PA.
The court reporter today is Dawn Halsasak of Merrill Deposition Services. Would the reporter please swear to the witness?
You swear that the testimony that you're about to give today in this matter will be true and accurate to the best of your ability and the pains and penalties of perjury in the state of Maryland?
Yes.
You state your name, doctor, spelling the last name for the record.
James Hamilton Black III. Last name is spelled B-L-A-C-K.
Thank you, counsel.
Doctor, I'm Rodney Gaston. I represent Kevin Tolson in the matter that's currently pending in the Circuit Court for Baltimore City. It's a medical malpractice action. The reason I've asked you to appear today for your deposition is because you've been identified by one of the parties as an expert who may provide expert testimony in this case. And that's why I've asked you to appear. Have you ever had your deposition taken before?
Yes, I have.
Okay. I'm just going to want to go over some of the ground rules so we can make an accurate record. If at any time I ask you a question you don't understand, please stop me immediately and say, I don't understand what you're asking me. And I'll try to rephrase the question. And if you don't interrupt me and don't tell me that you don't understand the question, we'll assume for the purposes of the deposition that you've understood the question and you've answered it accordingly. Also, if there's any time that you need to take a break, just let us know and we'll take a break.
Will do.
Okay. Doctor, I want to show you what's been marked as exhibit number 1, which is the amended notice of your videotaped deposition for trial. And I wonder if you've seen that document before.
Yes, I did. I can't remember when it was sent to me.
Okay. On page 3 is a list of documents that we asked you to bring with you to your deposition today. And I noticed you have a stack of documents in front of you. If you can simply go through and just list all of the items that you brought with you today for your deposition.
Actually, before you start to answer that question, I just want to note for the record that the most recent amended notice of videotape deposition of discovery deposition and for use at trial was delivered today. That did not have attached to it a list of documents that he was to bring to the deposition. So I object to the premise of your question in that there was no document request attached to the latest notice of deposition for which we are here.
Okay. So I have brought some handwritten notes that represent not really opinions, but just facts that I pulled out of the medical records. The medical records I reviewed are from the St. Agnes ER visit from December 3rd, 2009, the Concentra Medical Center record from December 5th, 2009, as well as the St. Agnes ER visit and admission on 12/5/2009. And then University of Maryland Medical Center records from 12/8 to 12/14/2009. Those are the medical records. I also reviewed the initial complaints. I have a couple statements from the qualified experts that I reviewed a long time ago. I must say I don't remember them specifically. First one being Larson, second one being Nurse Margison, then Dr. Nicholson. I also reviewed the expert witness designation, and I have a separate mailing that included the radiology studies from St. Agnes, mailed around April 2013, mostly related to the 12/3 through 12/7/2009. I also then received deposition testimony from Drs. Larson and Nicholson and Margison. And I don't know when I received it, but it was relatively recent. I have separate depositions from PA Shaw, Nurse Stell, and Dr. Jackson received in late August 2013. And I have the Tolson family deposition transcripts received late October 2013. And then I have Dr. Collier's deposition that I don't know exactly when I received it. I think I don't have my cover sheet. And then I also have the deposition testimony from Dr. Malik, M-A-L-L-E-K. And I also have the deposition testimony from Dr. Sarkar, which I received recently. And I think that would be everything.
You also had the triage Craddock.
Yes, that's included in some of the other depositions I have.
I don't think there's anybody else.
Have we covered everything you brought with you today?
How about, did I send you Anita Weiss, RN?
Yes.
Okay.
All right, have we covered everything so far?
I believe so.
Okay. And doctor, you mentioned that you've taken some notes in, as part of the review of this case?
That's correct.
Okay. We have marked as exhibit number 10. And I believe, does that exhibit contain the total pages of the notes you've taken in this case?
Yes, it does.
Have you made any independent notes on any depositions that you brought with you today?
Not that I can recall.
Okay. Have you made any independent notes on any of the medical records that you brought with you today?
No, I have not.
Okay. We have,
I did have this. This was a sticky that I put inside the chart. Sorry, we should have given this to you earlier. This is just a excerpt of laboratory values from 12/5/2009 when he represents to St. Agnes.
all right, well, why don't you read what you wrote on that little sticky for us?
Yeah. So this is a excerpt of myoglobin levels. Myoglobin is a byproduct of muscle breakdown. I wrote here myoglobin, then a colon, 12/5/2009 at 2:20 p.m. The myoglobin level is 1,649. That also his creatinine at the time was 1.5. Below that, I wrote likely 18 hours earlier, 8 p.m., December 4th, acute ischemia. So based upon my initial review some time ago, I thought the myoglobin levels were could reflect some of my professional opinion. I'm sure we'll get to that a little bit later, but I've also had additional materials from the medical record provided to me today that help firm up my opinion regarding the onset of the acute ischemia in Mr. Tolson. And those additional medical records that were provided to me today include Exhibit 12.
What is Exhibit 12? What is the name of that exhibit?
So Exhibit 12, I believe in my first mailing of medical records, I received the draft operative report from 12/7/2009. So the one I received today is the final operative report, which has a little bit better information regarding the muscle viability of Mr. Tolson's leg.
Just for the record, you have received that before today. I just gave you another copy today.
Okay.
Well, do you know when you got that?
This one? This one I received today. This is the medical records.
No, I gave you
Hang on a
I
sec-
gave
hang
you
on-
the.
Hang on a second. Let me ask the doc. When did you get exhibit number 12?
Exhibit number 12 it was given to me today.
Do you
That's
know-
when I remember reviewing it.
Do you know
About
if the contents of that document is contained within the binder that you have in front of you?
It is not in this binder.
Do you know if it's contained in any other documents that you have brought with you today?
Not that I'm aware of.
Okay, all right. Thank you, doctor. You can continue.
My statement for the record was that I have provided the finalized operative report to Dr. Black before today. He just didn't have it with him, and I gave him another one. I don't know whether he realized I gave it to him earlier or
Do you
not.
remember counsel giving you that doc?
It
or
was in
just-
one of my
do you-
email
Hang on a
doc-
second. Do you remember counsel giving you that doc?
Not specifically, no.
Okay. And do you remember the first time reading the final operative note? Was that today?
That was today.
Okay, all right. All right, let's go down to exhibit number, let's see, did we cover exhibit number 11?
Exhibit 11 was, my initial records did not include the complete discharge summary instructions for Mr. Tolson. So that was provided to me today.
Did Exhibit 11 change any of your opinions that you reached in this case?
No, not specifically.
Well, did it change any opinions, whether specifically or generally?
I think generally speaking, it seems like an appropriate discharge summary for a patient with an orthopedic injury.
Okay. And how about Exhibit number 12? Did that change any opinions that you previously reached in this case?
Yes, I think the fact that that the muscle was viable upon Dr. Wilkerson's initial fasciotomy, which was really his first step in his operative procedure. The muscle was quoted as muscle proved viable in all compartments, but did bulge significantly. So that it implies that the ischemia was actually probably closer to the time, the onset of ischemia was probably actually closer to 12.5 than it was to 12.4, as I had originally hypothesized based upon the myoglobin levels.
Okay. Is there a degree of viability that's noted in Dr. Wilkerson's report?
When a surgeon says that muscle was viable in all compartments, there are 4 compartments in the lower leg. And among the compartments, the one that tends to be the most vulnerable to ischemia is the anterior compartment. So when he says that the muscle was viable in all compartments, that's actually fairly reassuring. Sometimes in the acute ischemia arena, we see that the posterior compartments are viable, but the anterior is not, and that's not what was commented upon by Dr. Wilkerson. He said they were viable in all compartments, which is would imply to me, based on my experience, that the onset of ischemia was fairly close to the time of his operation.
And when he says we're viable, how do you interpret that word, viable?
Surgical, it's a surgical assessment, really. Viability, when you're inspecting a muscle, is based upon the color of the muscle. It's based upon the response to cautery, which is usually the one that most surgeons will use. And it also is dependent upon how much the muscle bulges, which he also commented the muscle bulged. So there's several factors to it. I frankly don't know how Dr. Wilkerson weighs viability, but viability from the standpoint of assessment currently, as I sit here today, means that his muscle was viable. I'm not to second guess Dr. Wilkerson's judgment.
And if the ischemia occurred closer to December 3rd versus December 5th, what would you expect Dr. Wilkerson's findings to be when he performed surgery on Mr. Tolson on December the 5th with respect to muscle viability?
Objection foundation.
Well, I guess I guess I would sort of agree with what Dr. Colliers said, your expert, that when he showed up on the 5th, he was with what's called a grade 2B ischemia. I think on page 58, Dr. Colliers says had he been ischemic for a couple days, his muscle would have been dead. So again, if the ischemia started on the 3rd, 46 hours or so from the time Dr. Wilkerson started his operation, then the muscle would not have been viable. It would have been what's called class 3 or grade 3, which is a non-viable extremity. And as Dr. Colliers said on page 59, it may have been another couple days they would have died. So he was saying, had it been earlier, i.e. the 3rd, he should have been looking at dead muscle, not viable muscle on the 5th.
When you talk about the onset of ischemia, is that in degrees? You're trying to figure out, when you're trying to pinpoint a date that ischemia occurs, is that a degree of ischemia? Is it slight, moderate, severe, or are other medical terms used to define the progression?
Objection to form.
I think that's a question I frankly can't answer in generalities. If we wanted to talk specifically about traumatic injuries to lower extremity and pulse loss and things of that nature, then it's easier to categorize ischemia. But certainly in the chronic phase, for patients who have extensive vascular disease, they tolerate longer periods of ischemia on their legs before they get into trouble, and younger patients tend not to.
Okay. And in this case, for a lower extremity? Is there, how do you define the onset of ischemia?
The onset of ischemia is, in the definition of acute ischemia, is the level of blood flow dropping below the point, at which point normal cellular function cannot be maintained. Normal cellular function on the leg can include nerves, can include muscle, can include skin appearance. So there's several ways that one can identify or categorize the onset of ischemia.
Can ischemia be reversed for a period of time?
I think you have to clarify that. I'm not sure what you mean.
Yeah. If the onset is a level of blood flow below which cellular function can be maintained, if ischemia drops below that level for a half hour, and then you have a return of blood flow, can that also result in a return of blood to the cells, and limit or stop the destruction of the cells?
Objection to form. I didn't understand that, but
I believe what you're describing is a phenomenon where someone has blood flow that is rapidly reduced, causes acute ischemia, and then upon restoration of flow, what would the outcome be for those various cells that had been previously under stress? So this scenario is called reperfusion injury. So in other words, perfusion or circulation to the tissues is stopped. It is then restored through either multiple ways, through surgery or medications or both, and then perfusion is resumed into those tissues, so what we call reperfusion. The behavior of cells after they are reperfused, even with adequate blood flow, even to normal levels or supernormal levels, is not predictable. So we have sometimes cells that oddly respond to it and seem to do fine, such as a nerve, and then muscles which may not, and they go on to die. So it's a very difficult thing to predict who responds and who is salvaged by revascularization, especially as the patient arrives in that window of time between 6 and 8 hours where we generally get concerned about overall ischemia.
Is there any way to know whether there was reperfusion in Mr. Tolston's case, Tolston's leg in this case?
Dr. Wilkerson, upon doing his first and second operations, performed bypasses to restore the normal, what I would call macrovascular circulation to the leg. In fact, his bypasses had a difficult time remaining open, and that can imply that there's been clot forming in the microcirculation, which makes it difficult for those bypasses to stay open.
Is that yes, did it happen in this case?
objection.
The clinical course, it's difficult to tell from the University of Maryland records, but even though his muscle was viable at the time Dr. Wilkerson operated on it, subsequently his muscle became non-viable at University of Maryland. So it's a little unclear to me whether that was a failure of the bypasses or a failure of the tissue and cellular mechanisms as secondary to reperfusion. But it's, from the operator, it's clinically indistinct.
Okay. And you don't have an opinion one way or the other whether that happened?
My opinion is probably he suffered significant reperfusion injury, and that made it difficult for the muscles to remain viable.
When you mean significant reperfusion injury, I thought reperfusion was the flow of blood back into the cellular tissue.
Right.
I don't understand what a reperfusion injury is. If you're supplying the tissues and cells with blood again, why there's an injury.
Right. So it's going to get a little technical here, but when cells become dysfunctional because of lack of circulation, they begin to produce things such as lactic acid, which is an acid that it'll then dump into the bloodstream. It can produce muscle breakdown products such as CPK and myoglobin. Restoring normal cell function requires oxygen to those tissues. Unfortunately, sometimes when reperfusion occurs, you get a lot of what's called simply put, super oxygen molecules, and those molecules can be injurious to cellular function. So despite the fact that we're bringing oxygen, the oxygen is not metabolized in a normal way. and then you wind up with compounding injury to the tissues.
That brings me to my next question. Is there any way to determine how much injury to the muscles in Mr. Tolson's leg was suffered by reperfusion as versus just ischemic changes that occurred
At what point in time?
the time that Dr. Wilkerson performed the operation?
I think my experience as a vascular surgeon is that it's very difficult to predict that process, so I wouldn't have an opinion.
Now, with respect to the onset of ischemia, does there have to be a quantity of cell functions that cannot be maintained in order to define the onset of ischemia?
Objection.
I'm not sure about your question, I'm sorry.
Okay, let's take into consideration Mr. Tolson's entire leg and his foot. Okay. If you're trying to figure out when the onset of ischemia occurred in his foot and his leg, is there a percentage of the foot or leg that has to show evidence of ischemia before you can pinpoint the time, such as the quantity of the limb that's affected?
Objection to form.
I guess I can only answer, based upon sort of the grading system, that Dr. Collier and I think I would agree on, that when he presented on the 5th, he was in what's called Class 2B ischemia, or Grade 2B ischemia. This is a classification system that looks at acute ischemia, and indeed, when you look at that classification scheme, one of the comments and criteria for the Class 2B is that most of the pain one experiences when someone's acutely ischemic is centered in the foot. And it's, and so in other words, for Mr. Tolson, the presentation where he comes back in, complaining of more foot pain is distinct and different than his initial presentation on the 3rd when he was complaining of more, diffuse lower extremity pain.
I'm still trying to figure out, is there a quantity of a limb that has to be affected before you can render an opinion that there's acute onset of ischemia in that particular limb? Such as half of the foot, quarter of the foot, half a leg, that's what I'm trying to figure out.
So-
Objection to form.
So if I create acute ischemia on your leg or my leg, presuming we have normal circulation, the tissues that are always injured first must be, and cannot be any other way, starts at the toes, the most distal portion of the circulation, and works upwards. That's the classical description of acute ischemia. Now again, that's a classical description, and it's not a perfect fit for a man who has concomitant traumatic injury on his leg, so you always have to weigh the various symptoms that the patient's reporting overall.
So it doesn't necessarily, the quantity of the limb affected is not the determining factor of whether there's an onset of ischemia. Is that correct?
Objection.
I guess you keep saying quantity, but I'm
Right,
trying to
the
say,
amount.
are you asking about quantity like the whole foot, the foot and half the leg,
Right,
the whole
right, all of that.
leg all the way up to the knee? I'm not aware of any reliable literature that talks about the quantity. I think we generally try and look at the quality of the pain complaint and the location. The quantity of the leg is something that's just not in the literature reliably.
Okay. You testified that your opinion with respect to the onset of ischemia was based upon the myoglobin levels on December 5th, 2009. Is that correct?
Correct.
And you said the level was 1649?
That's right.
Okay. Is there any other signs or symptoms of ischemia that surgeons such as yourself use to backdate the onset of ischemia other than the myoglobin levels?
Well, certainly the examination of the leg can be suggestive of the onset of ischemia, such that, for example, grade 3 ischemia, a non-viable limb, where there's no sensation, no movement, dead muscle, we know from the arena of vascular surgery that the onset of ischemia probably was, well past 12 or even 24 hours. Could even be up to 48 if you see dead muscle, as we talked about earlier. If you talk about, the intraoperative assessment, certainly, as we mentioned earlier with Dr. Wilkerson, the muscle was viable. That would suggest to me that the window of the acute ischemia was in sort of that class or grade 2B range, which is generally held that that's 4 to 6 to 8 hours of acute limb-threatening ischemia, where the limb is immediately threatened and in need of revascularization. So again, that brings the onset of acute ischemia onto the 5th, more so than any other day.
Can you have normal myoglobin levels and still have a class B ischemia?
The myoglobin usually implies that there's muscle breakdown, so you would have to be in the early stages of significant acute ischemia to have myoglobin being elaborated into the bloodstream.
And what is the levels we're talking about? This level was 1649. Is there a cutoff level that you use with respect to the evaluation of the myoglobin levels to determine the onset of acute ischemia?
It's certainly not an exact science. It's highly dependent upon the patient's hydration, could be dependent upon their overall kidney function. So it's a very broad stroke estimate. My clinical experience dealing with patients with acute ischemia, popliteal artery injuries, certainly in my practice is advanced injuries where you're getting the patient 2 and 3 and 4 days later, you have myoglobin levels in the 20,000, 30,000 range. So we're obviously much less than that with the myoglobins upon presentation on the 5th.
And what is the lowest myoglobin level that you've found that was consistent with an onset of acute ischemia?
I'm not sure what you mean by the question, I'm sorry.
Right. Is there, in order for you to render an opinion that there's an onset of acute ischemia, if you look at the myoglobin levels only, is there a particular cutoff where you say, based upon this, I don't believe there's acute ischemia, but if it goes above a certain level, then your opinion is there's acute ischemia?
No, again, it's not really the raw number. It's the trend of, for example, myoglobins taken hours apart. Blood flow status, for example, a completely dead limb on a patient, if they have little to no blood flow to the leg, they might not necessarily release any myoglobin because there's no blood to push the myoglobin back around the horn into the system. So it's a very, you look at the myoglobin from the standpoint of across a window of time, not as an isolated period of time.
Okay, so you can have little or no blood flow to a leg and still not have myoglobin levels elevated to the point where you could use them to determine the onset of acute ischemia?
Objection, mischaracterizes testimony.
Yeah, that's not exactly what I said.
Okay, why don't you repeat that again, because you testified that there could be little or no blood flow to the leg insufficient to push the myoglobins through the leg? Okay.
Objection,
So-
misstated testimony.
Okay, why don't you explain that again for me, doctor?
Yeah,
That's what I
so-
thought you said.
So the example I gave you was probably an extreme example. What we tend to see in patients who are hospitalized in the ICU on extensive medications to support blood pressure. In the setting of acute ischemia of the lower extremity, upon someone presenting to the emergency department with loss of circulation, to have that circulation be insufficient for days on end, I would expect to have a higher level of myoglobin. Again, that's a trending number. It's not an isolated number.
And I'm still trying to figure out what the lowest cutoff is, and I don't think you've told me that number, and maybe there isn't a number, so I'm just trying
so
to
I mean,
ask
the
you.
lowest, for example, the reference range for a myoglobin is as high as 72 milligrams per milliliter. And subsequently on his presentation, he's 1,600 when he shows up. He's a little bit higher the following morning. About 10 hours later, he's 2,145. And then after that, he's above 3,000. So I think there's, the trend of the number is important. To have a myoglobin level that just keeps rising usually implies that the muscle is not remaining viable despite our efforts as surgeons.
But I still don't think we have a bottom cutoff, do we?
He just told you the reference
No, you said
range.
72 milligrams was the
Top end of normal.
top end of normal.
Yep.
So that's where you start?
Yeah, I think so. I mean, again, I don't think we check myoglobins on every person who has their knee hit by a gate, so I don't know what a baseline number would be for this specific instance, but again, it's not the initial number, it's sort of what the number does over time.
Can the myoglobin levels increase gradually over a period of time versus rapidly over a short period of time?
Objection to what you mean by those terms?
I'm sorry, ma'am, can I get
I'm
you-
sorry, objection to what he means by those terms, rapid versus slowly over time.
Did you understand the question, Doc?
May just restate the question, I'm sorry.
Yeah, I'll say it again. Can myoglobin levels increase rapidly over a short period of time and also slowly over the same period of time?
I'm going to object to the foundation because we don't know what you mean by
Yeah.
rapidly or slowly. That's the basis. Right.
Go ahead, Doc.
I mentioned earlier that myoglobin, the kinetics of myoglobin are affected by kidney function, hydration, so there's a lot of variables that play into the rise in the myoglobin over time.
So can you have a very rapid increase of myoglobins over a short period of time, depending on the patient, the other conditions associated with the patient?
Objection.
My experience is usually the number increases slowly and steadily over days from the thousands range into the tens of thousands range. It tends not to jump in a 12, 24-hour period.
All right. Other than the myoglobin levels, are there other signs and symptoms of acute ischemia in the field of vascular medicine?
Are you talking about signs and symptoms? Clinical symptoms?
Signs and symptoms of acute ischemia in vascular medicine, other than the myoglobin levels.
Some of the clinical signs that suggest acute ischemia are lack of pulse on the extremity, specifically when the other extremity has a normal pulse exam or a better pulse exam. You can have a limb which is painful. Classically, as I mentioned earlier, foot pain starting at the toe, working onto the forefoot. The next would be pallor, that is a foot that is pale. The last is what's called poikilothermia, Poikilothermia, just means a cool limb. Just makes it all the P's. The other one is paralysis, and then the other one is paresthesias.
Upon the view of Mr. Tolson's emergency room record, did he have some of the classic clinical signs of ischemia?
He had symptoms, I believe when he presented, he included paresthesias and pain, but the pain really wasn't of the foot in the classic sense.
Was he also unable to move his foot?
I think at the end of the emergency department, after he had some pre-medication and some pain relievers, he was able to move the foot and the toes.
In the beginning when he came in, did he complain that he was unable to move his foot?
I believe so, but I'm not sure if that was a limitation due to pain or a limitation due to functional loss. I would believe, given the nature of his injury, it was the former.
Okay. And what would be an indication that his inability to move his foot was due to ischemia?
Objection.
What would be, I'm sorry, say
Right.
again?
Is there a different, you said, I'm talking about his inability to move his foot.
Okay.
Is there an inability to move his foot that's consistent with signs of acute ischemia?
No,
None at all?
none at all.
Okay. And it would have to be a motor function only?
Well, again, you have to remember, if like, we took yours and mine's artery and tied it off behind the knee, the first thing we would experience would, of course, be pulselessness. We would, by definition, to have acute ischemia, have to have a lack of a pulse, or at least an abnormal pulse in comparison to the other extremity. The next thing is the limb would be a little pale, and if I remember correctly, I think he's African American. Pallor is a very difficult thing to assess in African Americans. around 4 to 6 hours, you start to lose motor function. So if one was to hypothesize he wasn't moving his foot because of acute ischemia, well, frankly, the facts of the case don't suggest that at all. He had a normal pulse examination by 3 people over the course of an hour and a half or 2. So to have his foot not be moving on the basis of a proposed theory of, or mechanism of acute ischemia just doesn't add up.
Would that be assuming, you're assuming now that the testing and palpation of pulses was accurately measured by the medical providers that performed that service?
I would believe, looking at the contemporaneous medical records, having 3 individual people assess and testify that they felt pulses on this man is as good as concurrence as one could get for Mr. Tolson.
But your opinion is based upon the assumption that those individuals performed the palpation of Mr. Tolson's pulses accurately, correct?
Correct. I mean, the emergency department palpates pulses all the time. Matter of fact, there's a very busy vascular practice at St. Agnes from Dr. Wilkerson's at Tina. I'm sure that they have probably 5 to 10 patients a day running through their emergency room who are limb-related issues. So I'm sure this is an experienced group. This isn't a country hospital.
If Mr. Tolson's inability to move his foot was due to pain, would that be consistent with acute ischemia?
Again, the onset of ischemia, assuming a pulseless extremity, would start with inability to move the toes and then work its way upwards to inability to move the ankle. There would be quite a bit of time between that occurrence of those 2 fields. So again, to have him moving his toes well, pain-free at time of discharge is totally inconsistent with a theory of acute ischemia on the 3rd.
If he did not have an inability to move his toes at the time of discharge, and his toes and foot were actually cold at the time of discharge, would that fall within the time frame of the 4 to 6 hours of loss of motor function due to acute ischemia?
Objection to lack of foundation.
Again, I think, looking at Mr. Tolson's records, he had pulses present throughout his examination. And so I think the question really can't be answered. It's not really relevant to I mean, if it's a hypothetical, it's not relevant to the case.
Is it your testimony that whether or not Mr. Tolson's foot was cold to the touch and he was unable to move his foot at the time of the discharge is irrelevant to this case?
In the setting, I've been asked to render an expert opinion regarding the vascular status of Mr. Tolson over these several days. It's my opinion that he had a normal vascular examination upon his presentation and stay on December 3rd at St. Agnes. That's consistent with his medical records. To have a cold foot with a palpable pulse could just as easily imply stretching of nerves or neurologic injury due to the ligamentous injury that occurred around his knee and be totally unrelated to the vasculature.
But my question was, if it was true at the time of the discharge that Mr. Tolson's foot was cold to the touch and he had no feeling in his foot, do you still believe that that is irrelevant to the issues in this case?
Objection to the hypothetical.
Object.
Again, for Mr. Tolson, with palpable pulses, coolness of the limb was never documented by any of the examiners in the emergency department. And particularly when you start talking about paresthesias, which are very common with limb injuries. I've dislocated my knee 4 times. I know this personally. You can feel all sorts of things coming up the leg, pins and needles, hot, cold. So if the examiners feel his feet and they say they're not cold, but Mr. Tolson reports them as cold, that very well could be consistent with a mechanism other than acute ischemia. And we talked earlier that the time frame for nerve and muscular issues doesn't add up with his stay on December 3rd at St. Agnes.
back to my original question, which has not been specifically answered yet. If you assume, for the purposes of this case, that Mr. Tolson's foot was cold at the time he was discharged from the hospital, and he had no feeling in his foot at the time he was discharged from the hospital, if that turns out to be the facts in this case, is it your opinion that that is irrelevant to determining whether he had acute ischemia in his foot at the time of discharge?
Objection, asked and answered
I
twice,
don't.
I think.
I object also. The same reasons.
I guess what I've said, and maybe I'm just not saying it clear enough, is that for Mr. Tolson to have had a cold foot at time of discharge, and for you to hypothesize that that was related to acute ischemia, and then not be able to move his foot, all as part of the same equation, is not supported and more likely than not related to acute ischemia at the time of his discharge.
Okay, let's separate the two. Let's separate the cold foot versus his inability to move his foot. Same question. If his foot was cold to the touch at the time he was discharged from the hospital, is that fact irrelevant to your analysis as to whether he had acute ischemia when he left the hospital?
Objection, asked and answered 3 times now.
I think the only way I can, my opinion on the case is that at the time his splint was put on, for example, by P.A. Shaw, there was a notation, neurovascular intact. That is within minutes to it, who knows, at most a half hour, we're not certain, but to say his foot is cold or numb, and something changed between that contemporaneous medical records saying that everything is okay, and now at time of discharge, a very short period of time later, is not consistent with acute ischemia. You need hours for those symptoms to develop on the basis of turning off the circulation flat cold, which we did not do in this case. I mean, his circulation was intact.
Do you need hours of complete loss of blood flow to a limb in order for a foot to feel cold to the touch?
Well, I think there's a lot of variables that go into temperature of a foot, specifically after injury. I mean, was his leg uncovered by EMS? It's the middle of December. Was his leg uncovered on one side versus another in the emergency department? So I think temperature is obviously subjective, and I think to have low flow and have a limb be cool, again, gets more at the environment of the emergency room than anything I can hypothesize with any degree of certainty regarding levels of blood flow.
Do you have an opinion one way or the other as to the amount of decreased blood flow that Mr. Tolson would have to experience in his left leg in order for his foot to be cold or cool to the touch at the time he was discharged?
Objection to the foundation, I think, but
Need to repeat the question again?
Sure. Do you have an opinion in the field of vascular medicine as to what is the amount of decrease in the flow to the blood that would have to be present in Mr. Tolson's foot and leg in order for him to have a foot that was cool or cold to the touch at the time he was discharged?
related to ischemia?
Just cold to the touch.
Okay.
I think you have to give a context of why the foot is cold, if you want him to answer that question.
Did you understand my question or not? If you did, I can rephrase it.
I get, why don't you just rephrase it,
Sure.
I guess.
Okay. We're talking about change in temperature of a limb due to a decreased flow of blood.
Okay.
Now, do you have an opinion in the field of vascular medicine? What is the amount of decrease in the flow of the blood that Mr. Tolson would have to experience in the emergency room at St. Agnes Hospital in order for his foot to be cool or cold to the touch at the time he was discharged?
Objection.
Okay. So we know during his stay in the emergency department that that he was examined by several people, and the limb was never documented as feeling cold. In fact, there were pulses present. So what you're asking me is, for Mr. Tolson, could his leg have turned cold, I guess, at the time of his discharge, after having 3 people document that he had normal pulses for the prior 2.5 hours? And I would say the answer to that is no. It just doesn't, it's not consistent.
That's not what I'm asking. What I'm asking is, ignore all the examinations of the pulse. I just want to know, from a vascular surgeon perspective, for a man arrives at the hospital at 3:30 and he leaves at 5:50. And if he leaves at 5:50 with his foot that's cool or cold to the touch, what is the decrease in the amount of flow that he would have to experience over that period of time in order for his foot to be cool or cold to the touch at the time he was discharged?
I have to object again, Rodney, to your hypothetical. You are removing from the hypothetical what is necessary for the doctor to answer your question.
Well, I also object, Ron. Basically, you are assuming that there has to be, and the doctor's already, I think, explained this 3 times. You're assuming there has to be a decrease in blood flow for the foot to be cold. I think the
Which was my
doctor
first
testifies something
objection.
to the contrary. But go ahead. I object.
So I think there's a twofold answer. One is the foot can be cold on the basis of the environment in St. Agnes and have no relation whatsoever to the circulation at all. If one was to hypothesize the circulation was turned off, like turning off a faucet, the amount of, in order by definition for acute ischemia to be present, you have a pulseless extremity and the limb will become cool. That process, I would believe, would take hours, but I don't know, maybe you went out for a smoke and it was 10 degrees outside. I mean, environment plays a great factor in how fast a limb will cool, or for that matter, how fast it could heat.
Well, let's keep him in the ER where he was,
Yeah.
okay? Let's not take him outside.
Okay.
Could his foot, if he had a significant decrease in blood flow to his extremity,
Acute ischemia, you're asking.
well, we can talk about acute and we could talk about non-acute, and you'll have to define those terms for me, okay?
Yeah.
Could his foot have had acute ischemia from 3:30 to 5:50 if he had a decrease of blood flowing to his foot? And you can quantify that for me as to what amount he would need to have over that period of time in order for him to have that condition.
Object. Form, foundation. I don't think your question makes sense. I don't think that it's consistent internally, the question itself.
You can answer, Doctor.
So you just asked me what degree of blood flow or acute ischemia would have to exist during that 2 hours to have a cool leg.
You got it.
It would have to be total.
Total.
There'd be no blood flow coming down this man's leg at the time of his presentation to St. Agnes to have his foot remain cool, or at least be cool, at the time of discharge. And again, the pulse examinations are wholly inconsistent with that.
Okay. And for the entire time now, we're talking from 3:30 to 5:30, completely no flow, in your opinion, no flow of blood in order for him to have a cool foot at the time of discharge?
More likely than not, yes.
Okay. All right. Doctor, do you have a copy of your current CV with you?
I do.
Okay. And is Exhibit 8 a current copy of your
I think
CV?
I'm sorry, that's the current copy. I was thinking I had another copy, but
I
this
know.
is the current copy.
The font is a little bit small on that, so what I'm going to do, I'm going to hand you what's been marked as Exhibit number 2,
Okay.
which is a CV dated July 1st, 2013. And if you can simply compare and tell me what the differences are between the CV of July of 2013 and your current CV.
Right. So, in a interesting twist of some politics, perhaps, I'm labeled as Chief of Vascular Surgery from July 2013 onwards. In fact, that was held back a few months because of contract negotiations with another involved party, not necessarily me. So as of October 2013, I've been the Chief of Vascular Surgery, so that's a correction to what is listed on July 1. So I'm the Chief of Vascular Surgery and Endovascular Therapy at Hopkins. This says Exhibit 2 says July 2013. In fact, it's truly reflected on the Exhibit 8 where it says October 2013.
Okay.
In addition, additional title, I'm also the Regional Director for Vascular Surgery for Johns Hopkins Medical Institutions, which just means I'm in charge of deploying resources and people around the Baltimore area and even the National Capital Region to build vascular programs and assure quality vascular care. The remainder of the CV has probably only mild changes, mostly related to maybe a few additional publications or presentations. Most of my publications and presentations lately have been on what's called thoracic aortic disease or what's called aortic dissection or patients with what's called connective tissue disorders. These are patients who are just very prone for vascular catastrophe that I see very often.
And those would not be issues involved in this case?
No. Like I said, my research area and publications are mostly in those areas.
Do any of your publications that appear on any of your CVs are directly on point with the issues involved in this case?
Yeah, so I can point, we can just go through the exhibits. I don't think they've changed that much. If you just go to page 3, this is a list of publications. And as you can see, some of my earlier research and cited in number 2, as well as number 3, and number 4, and number 5, and number 6 are related to what's called acute limb ischemia, local responses to reperfusion, things along the lines of some of the things we've been talking about in terms of reperfusion injury, acute ischemia. Later on in the CV, there's a, under page 8, educational publications, there's a, under number 5, at least the first number 5, and the second number 5, looks like I need a new secretary. Since I'm the secretary, I guess I'll have to keep working. These are textbooks. The first one called Peripheral Arterial Disease. Again, just in that publication, there's discussion of acute ischemia. Number 5, the second number 5, Clinical Vascular Examination. That's a radiology textbook that we talk about vascular examination in that.
And in number 5,
Which
is
number
this
5? The first number 5 or the second number 5?
second number 5.
Yeah.
Is this a chapter that you wrote in a book or an article? I can't figure out.
Chapter in a book.
Chapter in a book.
Yeah.
And the chapter is entitled?
Clinical Vascular Examination.
Okay. And the book is Image-Guided Interventions?
Correct.
Okay,
2007.
Thank you, Doctor.
And then later on, under teaching activities, 2006, 2007, I was faculty for a course teaching endovascular techniques for peripheral arterial disease.
What page is that on, Doctor?
I'm sorry, that was page 12.
12. Is this the mentoring paragraph that we have?
I'm sorry.
My 12, I'm sorry. You have
Under
your micro version.
Yeah, under CME. There it
Page
is.
11 on the
Page
other.
11 on your other one.
Okay. Endovascular therapy for PVD,
Yeah,
course faculty.
as well as the next one.
Okay.
Endovascular procedures and techniques. It's
Okay.
just related to peripheral vascular disease in general.
Okay, can you tell me how long the CME programs were? Was it an hour, 2 hours, 3 hours, and where were they
I'm
conducted?
trying to recall, it's been a few years, as you can see, but I believe these were 2-day courses. I think it was a Friday and a Saturday. They were held in Baltimore at a hotel downtown.
Were you the only speaker there for
I
these
think we had
courses?
4. I think we had 4 faculty for each of those.
Okay, and do you know what percentage of the overall program the endovascular therapy PVD entailed?
It probably would have been a half-hour lecture as part of the morning session where we generally do lectures. So, I would probably do 2 or 3 lectures that day. And then in the afternoon, we have hands-on sessions using simulators with faculty who come in from out of town who want to learn new techniques. It's been, like I said, it's been a few years, but that's the gist of it.
Okay, go ahead, doctor.
And then I would just otherwise point out the editorial board appointments where I'm a reviewer for, on at least page 18 for me, this would be after organizational activities. Before recognitions, he just went by it, unless I changed.
I have professional societies, and it goes to conference activities.
There you go, it's at the top of this,
The top.
bottom of your page
Yes,
16.
yes, doctor, thank you.
So on my page 18 in the more updated CV, it's, again, these are essentially all of the journals that publish vascular surgery and endovascular techniques, and I'm a reviewer for all those. So in that capacity, I regularly review articles related to reperfusion injury, as I just did yesterday, actually, as well as peripheral arterial disease, aortic aneurysms, the whole spectrum of vascular disease, really.
Does your name appear on any of the articles that you're an editorial reviewer for?
No, it's that's by design, of course, because you'd want to keep the review process anonymous, the peer review process. If it was included names, that would bias our opinions.
Next question is, do you keep all the articles that you perform an editorial review on?
No, I'm instructed to destroy those so that they don't materialize in other people's presentations and publications by accident.
Okay, so we can't go back and figure out how many articles you've actually editorial reviewed because
they can
part of the,
yeah.
I'm sorry.
I could tell you I've generally done between 30 and 50 articles for each of these, with the exception of the duty textbook reviews. I've only done about 3. But it's a substantial actual commitment of time. Like I said, 30 to 50 for each of these publications.
Is it per year or during the period of time that's noted in the CV?
During the period of time. So circulation and yearbook of surgery, as well as cath interventions, have absolutely killed me in the last 2 years. So I don't know how they got hold of me.
Well, how much? It looks like you spend a lot of time reviewing medical articles for journals.
It takes about 4 to 5 hours a week. You know, it's sometimes it's nights and weekends. Sometimes I squeeze it in during the week, but it's not a small commitment. But I enjoy it. It helps me become a more effective medical writer myself.
Okay. Anything else in the rest of your CV?
No, I think that's it.
Okay. Doc, with your current position, are you still a professor of surgery or assistant professor of surgery at Johns Hopkins?
As of on the CV, it should say July 2010 to present. I'm associate professor of surgery at the School of Medicine. I also have an endowed chair, which just allows me some time for research.
Okay, and what do your teaching duties involve?
So I'm program director for the vascular surgery training program at Hopkins, which means I'm in charge of shepherding general surgery board-eligible surgeons to do additional subspecialty training in vascular surgery. I'm also an assistant program director for our general surgery program, so that's taking people out of medical school and shaping them up into board-eligible general surgeons. And I also provide lectures to the interventional radiology fellows, the cardiology fellows, the internal medicine house staff in the form of grand rounds. So I do quite a bit of teaching activity. I would estimate it's probably around 10 or 15% of my total time.
Okay, for shaping other doctors into becoming vascular surgeons, is that clinical hands-on on the floor and in the OR?
Yes, so vascular fellowships include some component of didactic teaching and lectures. We also, of course, have our residents and fellows present for the additional academic experience, but the vast majority of their time is spent in the operating room working hand in hand with us as faculty to learn vascular techniques and become proficient.
And how many vascular fellows do you have under your wing at any given time?
1 per year.
1 per year. And how long has that been?
We've had a vascular fellowship at Johns Hopkins for, I want to say, since 1999.
I meant for you.
Yeah, I've been faculty since 2004, so it's been 9 years of having trainees.
So during that period of time, have you, from 2004 to 2000, well, today, have you mentored 10 vascular fellows?
Roughly, yeah.
And how is that different from the other doctors that you mentor?
Well, it's clearly more of a closer relationship since I probably spend more time with those fellows than I do with my family. But obviously I have to train them in vascular surgery to be safe surgeons, to operate independently. It also includes imparting knowledge base so they can be good clinical decision makers, seeing patients in the outpatient clinic so they can understand the decision making that occurs outside the hospital as well as inside the hospital.
And on an average year, how many of those doctors do you have to supervise?
We have around 10 to 15 residents per year that rotate through the vascular service.
And are these all residents?
Those are residents. Those are lower level postgraduate years than the fellows who are obviously more senior.
Okay. So we got the residents and we've covered the fellows. Have we missed anybody else?
We have students also. The students sort of come and go like trains in the night, it seems lately. They have a lot of restrictions on their hourage that we can have them in the hospital.
And how much time is spent actually in the classroom on an average week doing classroom instruction for either the students, the residents, or the fellows?
We have, depending on the week, 2 to 3 hours of direct instruction to the residents and fellows as part of the vascular surgery rotation.
And in the division of vascular and endovascular therapy, how many vascular surgeons are under your current supervision?
We currently have 4 vascular surgeons, myself included. I also am at least partially responsible for the 4 vascular surgeons at Bayview Medical Center, as well as 2 vascular surgeons at Suburban Hospital down in the Capital Region.
No, but as far as in the division at Hopkins, where you work, it's yourself and 3 other vascular surgeons make
Correct.
up that division at Hopkins.
That's the core group. We had another vascular surgeon who recently left Hopkins to go be a dean at a medical school, so that was a promotion of sorts.
Okay. And do you actually, are you actually assigned to a particular patient for a vascular consultation? Okay, and how does that, do you get called down to the ER?
Right, so on an annual basis, I take anywhere from 150 to 175 days of call, I think when it all boils down to it. When we're on call, we handle all urgent and emergent consults that can occur from patients who are already an inpatient in the hospital, or it can be from the emergency room, or it can be on what's called the Hopkins Access Line, which is a phone-in line for physicians around the area to transfer patients. Okay. So we really run the whole spectrum of vascular disease when you talk about our call responsibilities.
Now, on those days that you're on call, when the call comes into you, can you delegate the call to one of the other 3 vascular surgeons under your supervision, or do you have to personally take that call?
I'll usually take the first call just to help sort of get the ball rolling, but ultimately if I feel that by virtue of a clogged schedule or something I won't be able to deliver the care timely fashion, of course I'd have my partner take over, or I would cancel the obligation and take care of the patient with the urgent consult over the elective surgery patients.
All right. And can you tell me, in the last 6 months, how many times you've been called to the ER for vascular consultation?
I would estimate we receive probably 2, maybe 3 vascular consults from the emergency department every day. Some of those may be related to, most commonly I would say, related to foot infections and diabetes, less commonly to acute arterial ischemia, but it's not an uncommon consult for us.
Now, 2 to 3 a day, does that mean, and for the last 6 months, how many times have you actually been called to the ER?
So over 150 days of call, anywhere from 300 times, maybe 400 times. Personal consults in the emergency department, I guess.
You board certified in vascular surgery?
Yes.
Are you board certified in any other specialty?
In general surgery, and I also recertified in 2012 or 13, I can't recall.
Did you pass your boards on the first time?
I did indeed.
Good for you. Thank you. Do you hold yourself out as an expert in orthopedic surgery?
I do not.
Do you hold yourself out as an expert in radiology?
Radiology of the vasculature, yes, that's certainly part and parcel of our training. Certainly when we perform vascular surgery as well as our endovascular therapy, we become proficient in identifying vascular studies, CT scans, angiograms as related to arterial and venous circulation.
How about the studies of the bones? The MRI studies, CTs of the bones?
Yeah, no, I'm not really proficient in reading CT scans of the orthopedic or skeletal system.
And how about of the ligamentous structures that support the knee?
No, my extent of my interpretation of such films would be to essentially read the final report, wouldn't be able to lend my own additional opinion.
So you would rely upon the radiologist impression?
For ligamentous and bony injury, sure.
All right. Doctor, are there any medical textbooks, journals, articles that you reviewed, consulted, or looked at in your evaluation of the issues in this case?
I believe after I read Dr. Colliers' deposition, where he commented upon flaps, and many of those will heal. That's a concept called minimal vascular injury. So I did look up one article related to occult vascular injuries and accuracy of physical examination, and that's your Exhibit 13. I must say it was a little bit cumbersome to read because it's an older article, so I didn't have the PDF, but at least I have the abstract.
Have you relied upon any information contained in that one article for any of the opinions that you intend to give in this case?
No, most of my opinions are formed from my own knowledge and experience, not necessarily this article.
Okay. Do you find that there are any medical journals, articles, textbooks that are reasonably reliable or authoritative for the medical issues involved in this case?
No, I think there are no authoritative references.
And you don't intend to rely upon any for the testimony that you will give in this case. Would that be true?
That is correct.
Okay. I have some more. Did you have a chance to review Dr. Sarkar's deposition testimony?
I read his deposition, but the exhibits were not included, so I didn't see the articles.
Okay. Do you intend to comment on any of the articles that Dr. Sarkar identified during his deposition that he relied upon in part for the opinions that he's going to give in this case?
I think we'd probably have to review his opinions as related to those articles, but and I don't recall exactly what they were as directly related to the articles. I had much more of a sense that Dr. Sarkar was speaking in generalities.
But at this point, you haven't reached any opinions one way or the other with respect to the accuracy of the facts, statistical data, or opinions reached by the authors of the articles that Dr. Sarkar referenced in his deposition. Would that be fair?
Objection.
I have no opinions as I sit here today regarding those articles.
Okay, thank you. Okay. Did you prepare a expert report that you signed for defense counsel in this case?
I did not prepare any expert reports, no.
Okay. Can you tell me when you were hired by, you can also take a break at any
Yeah,
time.
why don't we take a break so I can just catch up with a couple pages I see pop
Go
through here.
right, go right ahead, Don.
Okay.
We are going off the record. The time is 3:31 p.m. We are back on the record. The time is 3:46 p.m.
Doctor, are you licensed to practice medicine in any other state other than Maryland?
I am not.
Doctor, when did you first start offering services as a forensic expert in medical malpractice cases?
I believe it was around 2005 or 2006. And at the time, I was offered to look at a case regarding paraplegia after aortic surgery with an attorney named Kathleen Fallon. Part of the motivation to get involved in the process with I myself was being sued as a fellow at the Mass General regarding a case of pancreatitis after aortic rupture, and so I wanted to get inside the process a little bit and understand some of the things that I saw in my own experience. Subsequently, that case was, it was settled. No money was exchanged. It was settled. I forget the legal term. Dismissed with prejudice.
Dismissed with prejudice.
Yeah, there was no money exchanged. So, and that was the only time I've been involved in a lawsuit. But then since, I've just maintained the interest in studying medical records and rendering those opinions.
So what prompted your interest was because someone had initially sued you for medical malpractice. That's when you started to get interested in the legal process.
Correct.
Okay. Now, and that was your first time you were sued. I presume it's 2005, 2006?
That's the case would have come out of care delivered around 2003, 2004. And like I said, I think it was dismissed with prejudice around 2007 or 8. I just can't recall exactly.
Have there been any other medical malpractice cases filed against you other than the one that you just testified about?
No.
Okay. And when you first started to get into the realm of providing expert opinions, were they for the defense, for the plaintiff, combination of two? Can you give me an idea?
I would estimate, in terms of overall reviews, lately it seems mostly for the defense, because I've been doing a fair amount of reviews for Goodell and DeVries, as well as for PK that involve, hospital entities and things along those lines. But also, probably about 20 to 30% of the time, I do plaintiff reviews. In terms of actual depositions, I would say the percentage is probably 60% or 70% for the defense and 30 to 40% for the plaintiff. And I've testified at trial, I want to say 5 times. Twice was for the plaintiff for causation, and then 3 times, I believe, for the defense for either standard of care or causation.
Have you ever testified on behalf of a patient with respect to a breach of the standard of care?
Testified on behalf of the patient? No, I don't believe I had standard of care testimony in those. It was mostly causation.
Okay. And have all the times you testified been in the state of Maryland?
Actually, strike that. I did testify once on standard of care for a woman who had a popliteal artery thrombosis. Standard of care for vascular surgery. That was in Michigan.
How long ago was that?
That, I believe, was 2009 or 2010.
Do you remember the law firm that retained you in Michigan?
I don't remember the law firm, but the attorney's name was Scott Weidenfeller, which is Weidenfeller.
And your testimony was that you believe the vascular surgeon who operated on the patient for a popliteal artery injury breached the standard of care in that case?
Correct.
Okay. Do you have a copy of any of the depositions you may have given in that case?
I don't.
Okay. All right. And other than Michigan, has the other states you've testified have been in Maryland?
Correct. Washington, D.C., I provided causation for a DVT and pulmonary embolism case on a man who had peripheral vascular disease.
And that was for the defense?
That was for the defense.
Okay, so we got Michigan, we got D.C.
And
Need 3 more.
Virginia was the causation for the plaintiff for loss of limbs after head and neck surgery. fellow lost his legs, and that was with Gary Mims, M-I-M-S, and I believe he's in Fairfax.
How long ago was that?
3, maybe 4 years ago.
Okay. 2 more left.
In Michigan for the defense for causation regarding a man who died of splenic artery trauma. And I was defending the transfusion practices for the emergency department physicians.
Okay, 1 left.
I can't recall.
Okay, so it looks like,
Might be 4. I thought it was 5, but
okay, it looks like you've never testified in trial in the state of Maryland then.
that could be true. I believe that's right.
Okay.
Mhm.
And in this case, are you giving any opinions on the standard of the medical care that was provided by any of the medical providers?
No, I'm not giving standard of care for them.
So your opinion's solely limited to issues of injury and causation?
Injury and causation, I mean, although on some level I certainly understand interactions with the emergency department staff and have my own experiences in popliteal artery injuries that weigh into the opinion that are based upon clinical experience with other physicians.
Well, but you're not going to be addressing any of the actions taken by any of the nurses, the physician assistant, or the doctor in this case. Would that be correct?
Only the opinion that their care seemed consistent with the practice I would expect as a consulting physician, as a vascular surgeon dealing with the same.
That's a little hard to understand. What I'm trying to say is, my question is, do you tend to come into court and say, based upon the reading of the records in this case, you believe that Dr. Jackson followed the applicable standard of medical care for emergency room physicians treating this type of patient in this type of situation?
From the vascular surgery standpoint, yes, I would believe she did. I'm not talking holistically as an emergency department physician.
Well, and usually, in order to testify as an expert with respect to the standard of care of a doctor, you have to have experience as in the field of the doctor that you're going to come in to testify on behalf of, such as, in this case, Dr. Jackson is an emergency room physician. Now, are you board certified in emergency medicine?
No, I'm not.
Okay. And then back to my question is, I don't believe, and you correct me if I'm wrong, that you intend to come in here and say to the members of the jury, I reviewed all the care that Dr. Jackson did in this case, I reviewed the medical chart, I reviewed the evidence. In my opinion, she did not breach the standard of care in treating Mr. Tolson. Would that be fair? You're not going to come in and give that opinion?
No, I would give that opinion. I mean, I would say that she certainly performed an adequate and vascular examination for the clinical scenario that she was confronted with.
Okay, so that is standard of care opinion. Okay, so you're going to talk
With
about...
respect to vascular.
No, well, hold on a minute. It's standard of care opinion with respect to the actions taken by Dr. Jackson.
Jackson and Shaw, and as well as what I see as fairly standard nursing care.
So you're going to give standard of care opinions on behalf of Dr. Jackson, on behalf of Dr. Shaw, and on behalf of the nurses?
With the caveats that he's already testified to.
For the vascular care provided.
Well, that's still medical care, physician assistant care, and nursing care, correct?
If I'm asked to render opinion regarding whether or not any of them performed up to an adequate vascular examination and vascular assessment, I will freely give my opinion.
Okay. And when did you reach the opinions with respect to the care rendered in the area of vascular surgery by Dr. Jackson, Dr. Shaw, and the nurses involved in this case?
Upon review of the contemporaneous records and review of their depositions.
Did you wait until after you reviewed the depositions before you reached your opinions on the standard of care issues?
No, actually, I believe I received the records before I received any of the depositions, but even if I hadn't, my standard practice is always to start with the records before going to depositions.
What I'm trying to figure out is, did you reach your opinions that Dr. Jackson, Dr. Shaw, and the nurses did not breach the standard of care with respect to the vascular evaluation of Mr. Tolson before you had their deposition testimony?
For PA Shaw as well as the nurses, I reached that opinion looking at the records. I also used the deposition of Dr. Jackson, where she detailed what her portion of the care was that she delivered to reach the opinion for her.
Is there a reason that you were unable to reach an opinion with respect to the care provided by Dr. Jackson until you actually read her deposition testimony?
Most of the documentation in the emergency department is from PA Shaw on the 3rd, as well as the triage nurse and Nurse Stell.
Well, if you hadn't had Dr. Jackson's deposition testimony, would you be able to reach an opinion one way or the other, whether she breaches care with respect to the care and treatment of Mr. Tolson?
The deposition testimony was a contributor.
And that's what made the difference in this case, for your opinions?
Yes, that her involvement of the care was obviously much more detailed in her deposition than it was in the medical record.
Okay. Because from the medical record, we really don't know whether she actually examined Mr. Tolson, do we?
I object.
Objection.
I mean, looking at her deposition testimonies under oath, I always assumed that people are telling the truth. So,
No, that wasn't my question. My question was, looking at the medical chart, first, there's no way to determine from the chart itself if Dr. Jackson actually physically examined Mr. Tolson. Would that be a fair statement?
I object.
She subsequently signed the evaluation by Dr. Shaw, so in my practice, having PAs working under me as well as nurse practitioners, that's accepted practice. And that sometimes doesn't necessarily occur contemporaneously with when I see the patient. It could be when I sit down at a computer later to catch up on such things as signatures and co-signatures.
Well, what we're talking about is signing the chart versus physically examining the patient.
Right.
What I'm trying to figure out is, when you reviewed the medical chart from December 3rd, 2009, did you reach a conclusion one way or the other whether Dr. Jackson had actually physically examined Mr. Tolson on December 3rd, 2009?
I object.
My conclusion is, based upon my own practice and how we interact with PAs, that she very likely examined Mr. Tolson and subsequently signed the chart later.
But if you limit it solely to the medical chart and not what you do in your practice, would it be fair to say that there's just no way to determine one way or the other from the chart itself whether she had examined Mr. Tolson?
I object.
Under standard of care, those working with people underneath them, that they're responsible for their supervision. When you sign the chart, you are reflecting that you essentially agree with and did the examination. So if she signed the chart, then she examined the patient. For me, it's as simple as that.
So you concluded by the fact that she signed the chart on December 3rd, 2009, that she had actually examined Mr. Tolson?
Correct.
Okay. But from the chart itself, you didn't know what the extent of the examination was, correct?
I don't know if she repeated everything Dr. Shaw did or just portions. That was more detailed in her deposition.
But you don't really know what the examination consisted of because there's no evidence in the chart of that examination, correct?
Objection.
I think I've answered the question. I think she signed the chart, and then her deposition testimony said what she did, which is very similar to the efforts and care delivered by PA Shaw.
Okay. When you concluded that Dr. Jackson had examined Mr. Tolson because she signed the chart, what examination did you conclude that she had performed on him?
Objection.
I object.
I would conclude that for someone presented in the emergency department with trauma to leg, that she performed a neurovascular examination as well as assessed the knee. And of course took the standard history and physical. It's just common clinical care. It's nothing exceptional.
And with respect to the examination of the knee, what examination did you conclude that Dr. Jackson performed on December 3rd, 2009 by simply looking at the medical record?
That she performed an examination consistent with the findings of Dr. Shah by signing the chart.
And what type of orthopedic examination did you conclude that she performed on December 3rd, 2009 by looking at the chart?
I don't have specifics of orthopedic knee evaluations. That's certainly not an area where I'm an expert.
But you concluded nonetheless that she performed an adequate orthopedic examination of the knee, correct?
An adequate neurovascular examination and orthopedic evaluation, because it would appear at least that that's what Dr. Shah did. But again, I'm not an expert. I would defer to others if that was the case, or if there was differences on that opinion.
Did an adequate orthopedic examination of Mr. Tolson's knee require Dr. Jackson to perform the knee, to put the knee through a range of motion testing?
Objection. He's just testified. He's not testifying as an expert on orthopedics.
I can't testify what a mobility or laxity examination would be on a knee. It's just not something I do commonly in my own practice.
So you're not going to say, you don't have any opinions one way or the other, whether the orthopedic examinations, whatever they were, that may have been performed, met the standard of care, correct?
I don't have opinion upon orthopedic examinations.
Okay. You said you did have an opinion on the neurovascular examination that Dr. Jackson performed on Mr. Tolson?
Mhm.
Okay. Based upon the medical chart, what is a neurovascular examination that Dr. Jackson performed on Mr. Tolson?
Again, she signed Dr. Shah's, or PA Shah's note, and just pull up her note.
You're looking for,
Was she signed?
Yes,
PA
well, here's-
Shah's
I have
exam.
that. I have PA Shah's exam, that's what I was looking for. Which I have.
I-
Page 16 helpful?
I'm not sure our pages are the
It's
same.
yours. It's yours.
I know,
Yep.
but
Okay.
they've been redone
Okay.
so many times, I don't know.
Yeah, so I have this page.
Got
which is,
16?
It says 16,
Good.
yes.
Oh,
Okay,
there you go.
Doc.
That's easy.
Okay, so you concluded that Dr.
Mine's
Jack...
13.
Me too. Mine's 11.
So, Doctor, you reached the opinion that Dr. Jackson performed a thorough and competent neurovascular examination of Mr. Tolson based upon page 16 of the chart?
Yes, so if you look at the that page as well, page 15 before, this is what we call a comprehensive history and physical examination, and includes a chief complaint, a history of present illness. It includes multiple review of systems across multiple systems. Includes a family history, as well as what's called a 10-point review of systems, and even a greater than 10-point physical examination, including vital signs, head, neck, chest, abdomen, lower extremities, neuroevaluation, even psychiatric. And there's specific pointers put under the musculoskeletal. The left knee has positive swelling, tender on palpation, limited range of motion, as well as left leg and ankle tenderness on palpation, positive swelling, negative full range of motion, and plus pulses, 2+ BL, which means bilaterally. So, and then subsequently down low
Just go ahead.
on the neurologic examination, she clicks normal motor exam.
So I want to confine your testimony to the neurovascular examination because you're not able to testify as to what the proper or competent orthopedic evaluation would be, correct?
Yeah, you asked me about joint mobility and laxity, and those are things I can't testify to.
Okay, so I want to limit to the neurovascular exam.
Okay.
What on page 16 deals specifically with a neurovascular exam?
You have the vascular assessment of pulses. You have the gross assessment of the leg. You have
What about the gross assessment of the leg?
a gross assessment leg is basically looking at the appearance. As a physician, you generally take back the examination cover, look at the gross appearance of the leg. Is it swollen? Is it deformed? Basic physical examination includes palpation of the limb. You're looking for bony breaks in the skin, tenderness. All those things are performed. Limited range of motion. It implies the patient was asked to move, was not able to do that very well. You have pulse examination, which is essentially the backbone of the vascular examination. And then you have the neurologic examination a little bit farther down on the same piece of paper.
And on a neurological examination, what, if anything, was checked?
It says DTR is normal, that's deep tendon reflexes, cranial nerves intact, that's more of a head and neck thing. It says, I'm not sure if it says normal motor exam or whether that's on the sensory exam, but if I recall correctly, I believe he had sensation on the foot, so that might be a check that should be moved over a little bit.
Do you know one way or the other what that check is for which box?
I suspect it would be for normal sensory exam because we know that his motor exam wasn't normal because he wasn't moving his foot because of pain or his knee.
And based upon the information contained in page 16, it's your opinion that Dr. Jackson performed this examination on Mr. Tolson?
It says patient seen with PA, agree with care. So it could be that Dr. Jackson directly supervised it or she repeated portions of the examination herself.
Well,
I believe from her deposition, she repeated portions of the examination herself.
just from the medical chart, doctor, do you know one way or the other whether Dr. Jackson, from this signature, simply supervised this evaluation or performed it herself?
We can't say with certainty.
And is your opinion then based upon the fact that she did a proper supervision of the examination and or performed the examination herself?
Either of those would suffice for supervision of a PA.
Okay. Doctor, do you have a similar form such as Form 16 at the emergency room department at Hopkins where you work?
They've gone electronic down there in the last few months, so and there's actually 4 electronic medical record systems at Hopkins, so I don't actually interface with what's called HMed, which is their electronic medical record downstairs. So when we go down as consultants, we usually enter our own notes, type in the notes on the record.
Well, what I'm trying to figure out is from this box, from page 16, there's a box that can be checked. It says, I personally reviewed, examined, and performed the care of the patient. I've reviewed and discussed this case with the physician or MLP. The key elements are. That box wasn't checked, correct?
Yeah, so that's when you check that box, we have the same box in our record system at Hopkins for inpatient care. That's a box that you have to check if you're going to bill the patient. So from the standpoint of auditors with insurance, if that box is not checked, then theoretically the attestation is not sufficient for billing. So it doesn't necessarily imply that she didn't do all those things. It just means maybe she didn't plan on billing for the patient subsequently. I don't know how that all turned out.
Well, what I'm trying to figure out is, did you conclude that by the fact that Dr. Jackson didn't check the box that said she personally interviewed, examined, and participated in the care of the patient, that she did so, but didn't check the box because of billing purposes?
Objection.
Okay.
She did examine the patient and supervise her PA, didn't check the box, which could be for a variety of reasons, I suppose.
And you believe she did examine the patient based upon the words that are written in that box?
Objection.
I'm trying to figure out, what is your basis for your belief that she actually examined this patient based upon the medical chart only and not a deposition testimony?
Apart from the 17,000 things he's already answered?
It says patient seen with PA, so
Okay.
in this, in the way we supervise PAs, that includes examination, or is the direct observation of the examination.
Did your review of Dr. Jackson's deposition testimony change your original belief that she had supervised Ms. Shaw's care and not done the examination herself?
Object.
Objection.
I don't think I had a strong opinion on that either way. I think I looked at the records and thought that the supervision was appropriate, and it's the normal way that PAs are supervised. And documentation is reflected appropriately, that she was seen with a PA, agree with care.
Okay. And based upon, I think, your experience of how things are done in the emergency room, is the physician who supervises a PA supposed to sign the patient's chart on the day the patient's seen by the physician and/or physician's assistant?
Objection.
Object.
I'm not aware of a standard of care. I suspect that's more of a hospital regulation issue. For us at Hopkins, it could be anywhere from 24 to 7 days later. 24 hours to 7 days later. There really isn't a rule put on it that I'm aware of.
So the fact that Dr. Jackson didn't sign page 16 of the chart until 10 days later has no bearing on your opinion that she followed the standard of care in this case?
It has no bearing.
Okay. Did the fact that Dr. Jackson testified that the physician's assistant, she believed the physician's assistant ordered the Dilaudid in juxtaposition to the physician's assistant testimony that she thought Dr. Jackson ordered the Dilaudid, have any bearing on your opinion with respect to the standard of care by Dr. Jackson or physician assistant Shaw?
Objection to the characterization of the testimony.
I think it had no bearing, didn't mean anything to me. The records are 4 years old. The interactions with the patient are 4 years old. They might just have forgotten or confused the subject. I don't think it has any bearing on standard of care or responsibility.
Okay, so you believe that because of the lack of time that expired between the time the patient was actually examined and the time that the depositions were taken, that some of the memories may not have been accurate as to what exactly happened on December 3rd, 2009?
Objection. Rodney, that's inappropriate for this doctor, and you know that.
I think you asked me a question about a single Dilaudid administration to a single patient 4 years ago. It doesn't surprise me they couldn't remember. I don't think it bears any relevance to how they delivered care to the patient overall.
Okay. Would it make a difference as to whether they remembered other important aspects of the patient's care other than the Dilaudid for you reaching your opinion that they comply with the standard of care?
Objection.
I think as physicians we always try and remember the important parts of our care. I don't think that's an issue in this case. It seems as though they reflected that in their depositions appropriately.
Does it matter, in your opinion, the physician's ability to recall the events that they testified to in a deposition?
Objection.
Yeah, where they can recall the facts, then that's the nature of their testimony. I don't have any opinion as to how they recall it or what portion of the testimony they recall.
Did you assume, for rendering your opinions, that Dr. Jackson and Ms. Shaw accurately recalled their care of Mr. Tolson during the deposition testimony?
Object.
Objection.
I would believe their testimony is accurate.
Then what is the standard of care that's required of a physician's assistant who is performing a neurovascular evaluation of a patient such as Mr. Tolson?
For a patient such as Mr. Tolson with a injury to his leg, they want to rule out or assess the limb for the risk of a limb-threatening injury.
Is a dislocation a limb-threatening injury?
No, not in most cases.
Knee dislocation is not known as a limb-threatening injury?
And I've dislocated my knee 4 times. I still have my limb. It's a injury that can be associated with limb-threatening injury, but it is not a direct link or causally related to limb loss.
Okay. Isn't a dislocation a limb-threatening emergency because of the fact that the popliteal artery is often injured during a knee dislocation?
The popliteal artery is not often injured during a knee dislocation. The popliteal artery may be injured in specific types of knee dislocations. And in fact, it's not the dislocation which is the emergency, it's to reduce the limb back to a normal anatomic position, which is the emergency.
Are you familiar with any statistics or studies done with respect to how often a popliteal artery is injured during a knee dislocation?
No.
So the emergency is not the dislocation itself, but the reduction or relocation of the bones into the normal anatomical position that is the emergency.
To have the limb reduced to a normal location, so whatever variable stresses are placed upon the nerves and arteries and veins around the injury can be resolved.
Yeah. So in a case such as Mr. Tolson, if his knee has already been reduced or relocated to the normal anatomical position, then by the time he arrives in the hospital, then that should not be a limb-threatening injury.
With an intact neurovascular exam, yes.
Okay. With an intact neurovascular exam. Okay. Yeah. Doctor, for a posterior, do you have an opinion as to what injury Mr. Tolson sustained to his knee on December 3rd, 2009 when he got entrapped in the gate?
It's unclear exactly what injuries he sustained that day. We know from a subsequent MRI that he had several ligamentous injuries, including, I believe, the posterior collateral ligaments and some other partial tears of other ones. We also know he had an injury to the popliteal artery that was evident on the MRI on the 7th, although the timing of when the popliteal artery injury could have occurred cannot be said with certainty.
Well, do you believe he suffered a dislocation to his knee on December 3rd, 2009?
I'm uncertain. We know that he had his knee caught within a gate. I don't know if his knee dislocated or whether there was blunt force trauma to the knee. So I think it's unclear as to whether or not he had a dislocation at the time.
Is it because you do not have the training, experience, and expertise in the area of orthopedic injuries that you're unsure whether or not he dislocated his knee on December 3rd, 2009? My clinical experience with popliteal artery injury is that particularly in obese patients, such as like Mr. Tolson, 245 or 60 pounds, knee dislocations can in fact occur spontaneously. So it's possible he suffered a ligamentous injury without popliteal injury and had spontaneous dislocation after time of discharge from St. Agnes, and that could have then compounded a popliteal artery injury. So is it your opinion within a reasonable degree of medical probability in the field of vascular medicine that Mr. Tolson's knee dislocated after he was discharged from St. Agnes Hospital on December 3rd, 2009?
To degree of medical certainty, it is possible that he had spontaneous dislocation of his knee after the 3rd.
Well, we can't talk about possibilities in court. In a court of law, It's in, and the lawyers can correct me here if I'm wrong, within a reasonable degree of medical probability means more likely than not you believe something is so than not so. And my question is, do you have an opinion within a reasonable degree of probability, which means you believe more likely than not he suffered a dislocation to his knee after he left St. Agnes Hospital on December 3rd, 2009?
Objection.
Objection.
More likely than not, he would have suffered repeated dislocations of his knee after leaving on the 3rd.
So is that a yes?
Yes.
Okay. And how many knee dislocations do you believe, in your opinion, within a reasonable degree of medical probability in the field of vascular medicine, that he suffered after he left the hospital on December 3rd, 2009?
I can't say with certainty, but it's concerning to me that he was told not to bear weight on his leg, and when he presented to Concentra, there was no notation he was wearing his brace, and there was notation that he was walking on his leg. So any of those stressors could open the door for a knee dislocation to occur and compound a popliteal injury.
So, and how many times do you believe this happened after he left St. Agnes Hospital on December 3rd, 2009, until he arrived at Concentra on December 5th, 2009?
I don't have an opinion.
Okay. Do you have an opinion that it happened at least one time, or you don't have an opinion at all?
My opinion is that he was at high risk, and based upon his vascular examination on the 3rd, he must have suffered secondary injury to have the events unfold as they did on the 5th.
Okay. And the secondary injury that you believe he must have suffered had to be a knee dislocation, is that correct?
Knee dislocation or extension of the knee based upon his large weight or not wearing a brace, or both.
Okay. What is the evidence that you're concluding that he was not wearing a brace?
A knee immobilizer on a patient is a very bulky and evident item, and it wasn't commented at all on his Concentra records that he was wearing a brace or a knee immobilizer. And in fact, it was also commented that he was, had a antalgic gait, which means he was walking to the to Concentra,
Okay.
or walking at Concentra.
And is that the only basis that you're concluding he wasn't wearing a knee brace on December the 5th, 2009, when he arrived at Concentra?
Yes.
Have you then disregarded his testimony and his fiance's testimony that he kept his brace on his knee the entire time from the time he left St. Agnes Hospital on December 3rd, 2009 to the time he arrived at Concentra on December 5th, 2009?
I can't remember his exact testimony, but again, I relied upon the contemporaneous medical records, and certainly understand that it would be difficult for people to remember the exact times that they would have had it on or off, maybe to go to the bathroom or take a shower or anything. So I look at the Concentra records and that raises a great question in my mind as to whether or not he was wearing the knee immobilizer.
But you do remember his testimony where he said he kept it on the entire time, correct?
Right, exactly. And I'm just saying I'm not sure if that testimony is biased because it's been several years, but we don't know.
Well,
I can't say with certainty.
Well, what I'm trying to say is, have you set aside that testimony when you reach your opinion that you believe he took his brace off?
Objection. He's already answered this.
I question that testimony based upon the Concentra record.
Okay. So you question his testimony under oath and his fiance's testimony under oath that he kept the brace on based upon the Concentra record.
Objection.
That's what he said.
Is that true?
That's true.
Okay. Yeah. Is there any other reason other than that one note in the Concentra record that you believe Mr. Tolson sustained a knee dislocation between the time he left St. Agnes on December 3rd and the time he arrived at Concentra on December the 5th, 2009?
The additional basis for that opinion is my own clinical experience managing patients with multiple ligamentous injuries who can spontaneously dislocate a knee even in a knee immobilizer, especially when the patient is obese.
So you're also of the opinion that even if Mr. Tolson kept the knee immobilizer on the entire time, that more likely than not, his knee dislocated while he was wearing the knee immobilizer?
Objection.
Object.
He can dislocate, or he can hyperextend, or bend the knee, especially if he's walking on it. Any of those can place torsional stress on the structures around the knee itself.
And do you believe in this case that he either dislocated his knee, hyperextended his knee while he was wearing the knee immobilizer?
Objection.
My professional experience with management of these injuries is that that occurrence is more likely than not in an obese patient with a knee immobilizer with this type of injury.
Is that a yes?
I guess that's a yes.
Okay. All right. Now, do you have an opinion? I'll show you what's been marked as exhibit number 3. And this is the MRI report that was taken at University of Maryland Hospital on December 9th, 2009. And I think you touched on that a little bit in your testimony as to the type of injuries that was found on that study. Okay.
Okay.
Doctor, do you have an opinion within a reasonable degree of medical probability when the injuries that are outlined in that MRI study occurred to Mr. Tolson?
So they have mentioned a severe near-complete tear of the proximal PCL, a edema through the ACL with some moderate tear. There's also strain of the calf and other surrounding muscles and ligaments. It is likely that most of these injuries occurred when he was hit by the gate, but I can't completely rule out the possibility that there were other secondary injuries that occurred after the original injury. Again, because of my professional experience, is that these knees can dislocate or hyperextend even within a brace.
My question is, in your opinion, more likely than not, within the field of vascular surgery, do you believe that the injuries that are depicted and outlined on the MRI of December 9, 2009 occurred on December 3rd, 2009 when he became trapped in the gate?
I can't say with certainty, and the reason
no, don't mean certainty, just
Okay.
mean reasonable medical probability, which means you believe more likely than not.
I guess I can't answer the question then. I mean, I think I just call attention to the fact that when he was, that there was dramatic derangement of the knee that was noted in the operating room. So, the knee has to be taken out of the knee immobilizer to have the surgery. It remains a possibility that any of these injuries could have been worsened, during the subsequent care. So I can't answer your question.
You cannot answer that question.
Okay.
All right, now, so what are the injuries, if you can't answer the question addressing the injuries that are depicted on the MRI report, whether or not they occurred at the time that the gate caught his leg on December 3rd, 2009, are you able to give an opinion within a reasonable degree of medical probability, what if any injuries happened after he left St. Agnes on December 3rd, 2009?
Well, again, I'm not holding myself out as an orthopedic expert. When you talk about his vascular examination at St. Agnes on December 3rd, we have a normal pulse, 2+ bilaterally, among multiple observers. We do not have evidence of a vascular injury at the time that he comes into the emergency department. That I can say with reasonable medical certainty. In terms of the associated orthopedic injuries, I can't give you that opinion.
Okay, and back to my question was, what are the injuries, if any, that you believe within a reasonable degree of medical probability in the field of vascular medicine occurred after Mr. Tolson left St. Agnes Hospital on December 3rd, 2009?
The process of his vascular injury was for thrombosis of an area of popliteal artery, intimal tear or focal dissection. As that thrombosed, he then developed acute ischemia, which led to his representation initially to Concentra with complaints of numbness of the toes and foot and no pulses.
Okay, you said a mouthful, Doc. I'm trying to figure out the exact injury. Okay, you talked about thrombosis, you talked about intimal tear, you talked about associated ischemia. Let's break that down a little bit.
Okay.
Do you have an opinion, one way or the other, in a reasonable degree of medical probability in the field of vascular surgery, when Mr. Tolson sustained an intimal tear to the popliteal artery in his left leg?
No, I do not. I can't say with certainty whether it occurred on the 3rd or whether it occurred with secondary injury, but I have my professional experience is that there are usually secondary injuries from spontaneous dislocation, as we discussed earlier.
But you don't have an opinion as to this case when the intimal tear occurred in Mr. Tolson's popliteal artery, correct?
Correct.
Okay, now, do you have an opinion in this case? Strike that. Did you recall in the operative report that Dr. Wilkerson identified a pseudoaneurysm?
So it's an interesting portion of his operative note. So patients who have a arterial dissection or focal dissection or intimal tear, as Dr. Sarkar even believe he managed, mentioned you don't get a complete transection, but the artery wall can be weakened by the tear. Over time, that can produce a small aneurysm. That small aneurysm is called a pseudoaneurysm because it only involves one portion of the wall near the tear and not the other side of the wall where theoretically things are still normal. But it's also notable that the bleeding that occurred that led to the diagnosis of that popliteal pseudoaneurysm occurred when they were passing the vein graft through the area behind the knee, and they had dramatic bleeding. So it's possible that could have been a mechanical injury during surgery. That happens. It's the nature of vascular surgery. When you pass a catheter from behind to above the knee, it's a blind passage. So it's possible that could have been related to an initial event, but it's also equally possible that was just surgical trauma.
Okay, so would it be fair to say that with respect to the pseudoaneurysm, you do not have an opinion within a reasonable degree of medical probability in the field of vascular medicine when that pseudoaneurysm actually developed?
I'm suspicious that pseudoaneurysm was related to the thrombosis. I just can't say exactly when it would have developed.
Okay. Now, do you have an opinion within a reasonable degree of medical probability in the field of vascular surgery when there was an onset of thrombosis?
We sort of talked about this earlier when he presented with grade 2B ischemia on the 5th. I believe he arrives at St. Agnes at 11:09 a.m. And no pulses are documented. Its subsequent duplex shows very low flow through the tibial vessels. In that scenario, I agree with Dr. Collier, that was class 2B ischemia, and so to have that be the examination as well as a subsequent assessment of the viability of the muscles, I would believe the onset of ischemia probably occurred at some point early in the morning on the 5th.
And are we talking about the onset of thrombosis as synonymous with the onset of ischemia?
Correct.
Okay. And thrombosis simply means clotting?
That the artery clots off.
Artery clots off.
Mm-hmm.
Okay. Do you know how much clotting occurred in the artery before? Are you able to determine how much artery clotting may have occurred before the morning of December 5th, 2009?
If the artery had sustained enough clot to create acute ischemia, then the muscle would have been non-viable when it was explored at roughly 5 or 5:30 p.m. on the 5th. So my belief, more likely than not, is that the onset of both thrombosis and significant diminishing flow and the acute ischemia is all contemporaneous around the 5th, early in the morning.
Okay. What injury caused the clotting?
Would be a popliteal artery focal dissection or intimal tear, which could have occurred anywhere in the prior 2 days based upon his injury.
Okay. Do you believe there was actually a focal dissection of his popliteal artery, or more likely than not, it was an intimal tear?
They're the same thing.
They're the same? Oh,
Yeah,
sorry, they're
it's the same
exactly
thing.
the same.
Exactly
Use them
the same.
interchangeably. Okay. All right, thank you. All right. Is there any evidence in the chart or from Mr. Tolson's deposition testimony that he sustained a traumatic injury to his knee after he left St. Agnes Hospital on December 3rd, 2009? Traumatic injury, I mean a force to the knee, some outside force, some trauma to his knee.
No, there's not.
Okay. Is there any evidence that he had any injury to his knee before the gate trapped him on December 3rd, 2009?
Not that I'm aware.
Does a dislocation of the knee require high energy?
The classical description of knee dislocation is a high energy impact, usually with the knee hitting a dashboard in a car. Or if you're Napoleon McCallum playing for the Raiders, you get hit on the front of your knee by a linebacker as you're coming through the line of scrimmage. But with with other concomitant multiple ligamentous injuries, theoretically the knee can be so unstable that you can hyperextend or torse the knee in a way that the artery can become stretched.
With respect to all of the ligamentous structures that we show injured on the December 9th, 2009 MRI, do you believe that there was a high energy trauma to Mr. Tolson's knee on December 3rd, 2009 that caused those injuries?
From what is described with the motorized gates, I don't believe that's high energy. High energy in the classical description of trauma usually implies high velocity, traveling at a high rate of speed, things of that nature. And it sounds like this structure was a slow, steady force applied to his knee.
So you believe it was a slow, steady force applied to the knee that resulted in the tearing of the internal ligaments and structures inside his knee?
That, or with combination of a fall after he was hit, once the knee can buckle, of course.
Do you understand from reading the chart that Mr. Tolson sustained a twisting injury to his knee on December 3rd, 2009?
You can look at the record.
Yeah, I think I have to look at what the chief complaint was, but I do.
I'll show you I'm sorry, let me strike that back. Have you had a chance to review the EMT report?
Unfortunately, EMT reports didn't copy so well for me, so I did not review it, no.
Did defense counsel give you a legible copy of the EMT report?
I don't believe I asked for it.
Okay. Would your opinion change depending upon what was contained in the EMT narrative as to how Mr. Tolson was injured?
I object.
Objection.
I don't know. I mean, I guess you'd have to let me read the report, and then I can tell you if it changes my opinion.
Okay, I'll let you read the report.
That'd probably be the easiest way.
Sure, go ahead, Doc.
So this is the Maryland ambulance record for Kevin Tolson. The date is 12/3/2009. The time of 911 call is 2:23 in the afternoon. The ambulance arrived 5 minutes later. That's great, nice and fast. And then returned later on. So the initial ambulance reports also qualifies the injury type as a fall.
You're holding the paper right in front of your face, Doc. I'm sorry.
Okay, sorry.
Thank you. Go ahead.
Qualifies the injury type as a fall, and then talks about his initial vital signs as essentially being close to normal. The patient is subsequently transported. He has oxygen applied, and he's sent to the receiving hospital, which is chosen because it's closest to the area, to the place of injury. The chief complaint is elaborated by the emergency medicine technicians as a patient having a fall due to having his foot stuck in a security gate. And there's some abbreviations I'm not familiar with, but essentially the patient was lying on the ground, was walking to his vehicle when he stepped down onto the security gates and his foot was stuck, and then he twisted and fell to the ground, and that the pain was localized to his left knee, and he was transferred to the hospital without incident. Various comments related to no loss of consciousness and no evidence of head injury. Left knee did have swelling and an ice pack was applied and the knee was splinted. So the mechanism elaborated as a fall with a twist.
Is that one of the ways that a knee can be dislocated?
It would be extremely uncommon. I definitely have not heard of many instances where a body can simply twist and dislocate a knee, but perhaps the gates exerted additional torsional stress other than his body twisting alone.
So it is possible that the mechanism of injury that's described in the report, the narrative by the EMTs, is consistent with a dislocation.
I object.
Objection.
I don't think it's necessarily consistent with dislocation. It's probably consistent with a ligamentous injury, but I don't know about dislocation. I don't think the detail is granular enough to come to that conclusion.
The foot being caught in a gate and he twists his body and then falls. Is the foot being caught and then the body twisting a way that a dislocated knee can occur?
Objection.
I don't know. I guess you'd have to study the anatomically exactly how he fell. If I've caught my ankle and I've dislocated my kneecap, didn't do anything to my posterior collateral ligaments or anterior collateral ligaments. So, I guess anything is possible. Whether it's medically certain that this resulted in knee dislocation is impossible to say.
Okay. And you're not going to give an opinion one way or the other whether Mr. Tolson did or did not dislocate his knee as a result of being trapped in defense on December 3rd, 2009, are you?
Say again.
You're not going to give an opinion one way or the other whether Mr. Tolson dislocated his knee when his leg became trapped in defense on December 3rd, 2009, are you?
As I mentioned earlier, I can't say with certainty exactly when his knee would have dislocated if it did so at all.
Does that mean you're unable to give an opinion?
I'm unable to give that opinion.
Okay. Okay. Is the palpating for pulses a reliable or unreliable method to determine a decrease of blood flow in a patient's extremity, and particularly into his foot?
Palpation of pulses is clearly a skill that people acquire over time. Some people are good at it, some people aren't. But the specific presence of a pulse, at least in symmetry to the other leg, is a very reassuring finding, regardless of how one wants to grade or term the pulse character itself.
Well, getting back to my initial, is it, in your opinion, a reliable or unreliable method to determine the flow of blood into a person's extremity?
Objection.
Pulse examination is part of the standard of care for determining presence or absence of acute ischemia.
In your experience, how many popliteal artery injuries have you personally treated?
4.
And in your experience, did any of these popliteal artery injuries result from a dislocation of a knee?
Very similar to this case. We can't say exactly when the injury did occur. In 2 cases, they were associated with young men playing athletics who had at least one a slide tackle and the other one unsure of who hit him when. But both those patients were evaluated initially, had splints put on, and anywhere from 3 to 4 days later developed foot pain and came in for vascular reconstruction. We had another patient recently who was at a construction site and was struck, sustaining orthopedic and vascular injury. And that one was obvious because he's required a CT scan of the leg to evaluate his complex orthopedic injury, and that's what diagnosed the vascular injury. And then lastly, we had another patient spontaneously dislocate their leg after sustaining ligamentous injuries, and that led to a change in examination detected by the nurses, who then led to a vascular consult and subsequent vascular reconstruction.
And this patient with the spontaneous dislocation of the leg, did that occur while he was in the emergency room for his initial injury, or did he come in for initial injury, went home, then had a spontaneous dislocation in return?
It was a 34-year-old woman who weighed about 420 pounds, and she suffered what she felt was a buckling of her knee and was in the hospital, and then had another round of knee pain, and apparently was then diagnosed with a spontaneous dislocation, which is actually a fairly well-described phenomenon in the obese, and that led to our consult. So she was actually in the hospital when it occurred.
Doc, is there any way to determine the percentage of the decrease in the flow of blood into a patient's limb by simply palpating for pulses?
If the pulses are symmetrical, there is no decrease in flow, especially across multiple examiners. If one pulse is different than another and annotated as such, then that would be an indication to consider further testing.
What I'm trying to say is, and maybe I ask it wrong, is there any way from simply palpating a pulse that you can determine the percentage of the decrease of blood that's flowing into the patient's limb?
Objection. Just
Okay.
asked and answered.
To have a palpable pulse implies normal to very near normal circulation.
And on a scale from 1 to 100, with 100 being full, complete flow, 0 being no flow, what is the normal range we're talking about? What percentage?
Objection.
I can't give you a perfect answer. We know that on ankle brachial index testing, which is a standard screen for vascular disease, normal is a ratio of 0.9 to anywhere to 1.2 to 1.3, depending on the vascular laboratory reading the studies. So, for example, I have patients who are young and otherwise normal with an ABI of 1.1 on one side and 0.9 on the other, and it offers them no symptoms and they have no overt changes in their vascular examination. Generally, when in the vascular surgery world, to lose a pulse in the legs, we see this in people with vascular disease in a chronic fashion. Most of those patients will have an ABI of 0.6, perhaps 0.7 at best. So it's a substantial reduction from baseline to lose a pulse.
Okay. Normal 0.9 to 1.2 to 1.7 or
1.3.
1.3?
Yeah.
So acrobrachial index of 0.89 would be abnormal.
Like I said, I have patients who are close to that. In our own vascular lab, And I'm a registered vascular technologist, so I can read and interpret these studies, and I'm accredited as such from a credentialing body. In our lab, we don't really call anyone other than minimal until they get under 0.8 to 0.7. When we get down to 0.6 or 0.5, we call them moderate arterial insufficiency. We don't really call people severe arterial insufficiency until they get under 0.3.
What value do you assign to an abnormal blood flow?
What?
I think I just tried to answer it. We won't really call anything abnormal until it, I guess I can't answer the question. Our terminology is minimal, mild, moderate, and severe. Abnormal is a clinical assessment.
Okay. Well, if a person has a brachial ankle index of 0.89, let's assume that the other side's normal 1.0.
Okay.
Is that enough to warrant, actually, what would that, from a clinical standpoint, mean, if anything?
In and of itself, of course, we never treat numbers, we treat the patient. So if someone had a 0.89 and they had palpable pulses, as I would expect they would, and probably very much symmetrical to the other side, that would prompt no further workup.
I've read in the literature that a person can have a popliteal artery injury and still have palpable pulses. Is that your experience?
Yes, that's definitely a possibility.
Okay. And what I'm trying to figure out is if a person has a popliteal injury but palpable pulses, what's the next step that a clinician or a vascular surgeon such as yourself would do in order to determine the extent of the popliteal injury?
Well, in the, I'm sorry, say the question again. Are you
Right.
talking about? Yeah.
If a person can have a popliteal injury but still have normal pulses, okay? What I'm trying to figure out, how do you determine the extent of the popliteal injury if there's still normal pulses in that person? Do you do a further diagnostic study to measure the flow of blood into the person's leg?
Object to, I think there's a lack of foundation, but go ahead.
I think that the standard evaluation that we will sometimes see for diagnosing a popliteal artery injury that is what we would call subclinical, so it has no outward physical examination manifestations. Those are what we call incidental findings, minimal vascular injuries, and we tend to see those as incidental findings on CT scans done for other reasons, such as the patient I described with the complex orthopedic injury that, lo and behold, we discovered a popliteal artery issue. So I think it's the answer can be difficult to ascertain. It's clearly patient dependent. For Mr. Tolson, it's unclear what the next step would have been. He has a palpable pulse from multiple examiners and has no pain in his toes and his foot. He's isolated to the knee and the calf, so it's not a consistent examination from the clinician standpoint to prompt a consideration of arterial ischemia.
Is deformity in a patient's knee a sign of a dislocated knee?
No, I don't think so. I mean, my own experience, professional and personal, is that most patients with ligamentous injuries in an isolated fashion will have some form of a knee effusion. So just because one has deformity or effusion in the knee doesn't imply that they have a vascular injury. We talked earlier about dislocation as being a different beast, but that is not the case
Hang on a
for
second.
Mr. Tolson.
You lost me. Deformity and effusion is or is not suggested of a dislocated knee?
Deformity and effusion are universal in ligament injuries and therefore not suggestive of a vascular injury
Well,
based upon that finding alone.
no, I'm not talking about vascular injury. I'm talking about dislocation.
Oh, dislocation.
Dislocation, maybe I misunderstood the question. Is deformity and effusion consistent with a patient who has a dislocated knee?
Objection.
Yeah, it's difficult to say. I would imagine every person who has a dislocated knee has a deformity, but not everyone who has a swollen knee has a dislocation. Sort of like every dog is a German Shepherd, but not every
You got it backwards.
every German Shepherd is a dog, but not every dog is a German Shepherd.
If a person such as
You
Mr.
can object to my answer, I guess. Everyone else is objecting. I don't want you to feel left out.
I'm just trying to figure out if, in a patient such as Mr. Tolson, and we know from his chart, the triage nurse noted deformity. We also know from the x-ray that he had effusion in the knee. Are those two findings classical symptoms of a dislocated knee?
My answer would be classical no. Common symptoms of knee injury are effusion and deformity.
And do you include knee injury as a dislocation?
Ligamentous injury, dislocation, I think they all could produce what you just described.
Okay. All right. Now, does the extent of the ligamentous injury, such as the more severe, give a higher suspicion for a dislocated knee?
I think that's very dependent upon which ones are injured, what pattern, mechanism of injury. I don't think I can answer that question with a great degree of medical certainty.
Okay. You did read Dr. Collier's deposition testimony?
Yes.
And I believe you took some notes with respect to that?
Right.
Okay. I think you already testified as to some of the things you agreed with Dr. Collier. My question is, what are the opinions, what is it about Dr. Collier's deposition testimony that you disagree with from a vascular surgeon perspective?
I'm going to object because it was a relatively long deposition, and I think that's putting this doctor in a bit of a hard spot to come up with everything he disagrees with. But
Doctor, you can
handle it as you
You
want
can
to.
take as much time as you want to read it, because the reason I'm asking the question is that I don't want to get to trial and have the lawyer that hired you say, tell me what about Dr. Collier's deposition you disagree with, and you have not told me that today. So I don't want to be surprised, and that's the reason that I'm asking the question. So if you need to take some time to go through that, I really need to know today before we leave, what is it about his opinions or analysis that you disagree with from a vascular surgeon, a vascular medicine standpoint?
I'm going to object to the way you phrased that little speech.
Well, I mean, I think, I would rely on my notes. As I said in that note, page 93, he has a comment, an effusion and nerve injury, like I said, it's either that the nerve was stretched so much that it was hurt, in which case it had a dislocation, that there is a false aneurysm, which we know now, or that there was an ischemic injury. You need to consider those and rule them out. I mean, they're dangerous not to. And so I think I would disagree with him that, first of all, that an effusion and a nerve injury is synonymous with knee dislocation. I think there's probably a lot of reasons that a leg can have some paresthesias after having ligamentous injury. And I also disagree that a false aneurysm was started on the 3rd. It's also possible that was just surgical trauma on the 5th. And later on, there's a discussion about that palpation doesn't affect his opinion, and he says that pulses, again, don't really factor in. And I think that that's a completely theoretical argument. In fact, as a clinician evaluating patients, pulses is the backbone of how we evaluate arterial injury. On that level, I would disagree with that portion. of his testimony.
Okay. Is effusion and nerve injury, even though you disagree that it's synonymous with knee dislocation, is it associated with knee dislocation?
Objection asked and answered.
I don't think I could say with certainty. That probably goes more to orthopedic experts.
So you would not render an opinion one way or the other whether effusion and knee injury is synonymous or associated with knee dislocation. Would that be a fair statement?
Objection.
I think I said earlier, I would assume dislocation always produces an effusion. The component of nerve injury and paresthesias, I would also suspect is a very common thing with ligamentous injury. But again, I'm not going to render opinion. I'll resolve that to a orthopedic doc.
Okay. And you testified that with respect to the false aneurysm, I thought we went over that you didn't have an opinion within a reasonable degree of medical probability when the false aneurysm occurred. Is that correct?
Right. Well, he's implying, of course, that the false aneurysm was occurred right on the spot on the 3rd, and I don't think we can say that with certainty. That's a disagreement I have with him.
So is it your opinion within a reasonable degree of medical probability that the false aneurysm did not occur on December 3rd?
Objection.
I think aneurysmal degeneration of a intimal tear is a process that occurs over days to weeks, so I would not believe to a reasonable degree of medical certainty there was a false aneurysm on the 3rd.
Do you know when it occurred?
Can't say for certain.
Okay. Have we discussed all of your disagreements with respect to the testimony provided by Dr. Collier?
Same objection as before.
As I sit here now, I think that's the extent of the majority opinion.
Okay. Did you have a chance to review Dr. Sarkar's deposition?
Yes, I did.
Okay. I think you took some notes on that as well?
I took some notes.
Okay. Can you, Doc, I can't read your notes, so if you could just read what your notes are, so that when I go back through this, I can figure out what you wrote. I'd appreciate that.
Okay. I'm sorry? Okay. So, Dr. Sarkar's deposition, I have a comment on page 94, lines 4 through 7. Actually, we'll start at maybe up on page 93. St. Agnes has board-certified vascular providers who are experienced vascular surgeons. The mechanism of injury in this case, I think, would have been evident on physical examination in terms of mobility of the knee. And most vascular providers would have obtained one of 3 studies, in addition to the ankle brachial index and a patient with this type of knee injury, if consulted. And so I think he's implying, of course, that all those things should have occurred. And in fact, based upon the history and physical and the purported mechanism of injury, I would not believe a vascular consultation was indicated for this man with a palpable pulse and resolving pain at time of discharge. So I disagree on his statement there that was necessary.
Okay, I'm trying to figure out, do you agree with the other statement that if a vascular consultation had occurred, that the studies that Dr. Sarkar testified to would have been reasonable?
I can't remember the other 2. He obviously only mentioned the ABI there, but I would sort of defer to his own statement a little later down 94. I cannot guarantee that a vascular consultation would have resulted in prevention of amputation, but early intervention is unequivocally better than late.
And what are the vascular studies that could have been done to determine the extent of the loss of blood flow, if any, in Mr. Tolson's leg, if they had been done on December the 3rd? What are the types of studies that could have been done?
Objection. Why don't you get one question out? We've got 4 of them in there.
Did you understand the question, Doc, or do you want me to repeat
Maybe
it?
just repeat it, I'm sorry.
Okay. If Mr. Tolson had had a vascular consultation on December the 3rd, What are some of the studies that a vascular surgeon could have ordered if the vascular surgeon believed there was a vascular compromise?
Object.
Objection.
Standard vascular evaluation could include an ankle brachial index to rule out arterial insufficiency, what's called an ultrasound evaluation of the area, which I highly suspect would be pretty useless in an obese man with limited range of motion. And then the others would be invasive studies, such as a CT scan or an angiogram, which require radiation, IV placement, contrast exposure, dye reactions, other things. So those generally are indicated when one identifies and thinks they're going to be moving ahead with an intervention.
And if Mr. Tolston, in fact, had an intimal tear to his popliteal artery on December 3rd, 2009, could one of those studies have detected that tear in his leg?
Objection.
I can't say with certainty. I don't know for certain that he even had an intimal tear at that time.
What I'm asking you to do is assume that he had an intimal tear on December 3rd, 2009. Within a reasonable degree of medical probability, more likely than not, could one of those studies have detected the intimal tear?
Object.
Objection to the, go ahead, objection.
I don't know the exact percentages of sensitivity and specificity to detect, which at best would have been a minimal vascular injury on the 3rd if we're hypothesizing there was something there.
So you don't know one way or the other?
I don't know if the percentage of detecting these in someone with a normal pulse examination is going to be 50%, 70%, 90%.
Well, if he had an intimal tear that was reducing the flow of blood into his leg, would one of those studies have detected that tear and have detected the reduction of the flow of blood into his leg?
Object.
Objection.
But we're not talking about, I mean, are you giving me a hypothetical? Because clearly he didn't have a reduction of blood flow into his leg on the 3rd.
In your opinion, he didn't, but in Dr. Sarkar's opinion, he did, correct?
I don't really know about that. I mean, he said intimal tear on page 16, line 20. He said the subsequent course is very typical for this type of injury. He said he wasn't salvageable by 11 p.m. On line 1 through 14 and page 101. I mean, that's just flat out wrong. I mean, there's no evidence of a lack of pulses that could produce a non-salvageable limb by the 3rd at 11 p.m. So I mean, I frankly don't know what to make of Dr. Sarkar's opinions along those lines. I just think he's off base.
Do you understand the basis for his opinions, that there was evidence of ischemia in the chart separate and apart from Mr. Tolston's deposition testimony?
We've already gone over this from the medical chart. He had intact pulses from 3 providers. Whatever he hypothesizes, I disagree with in terms of viability of a limb being compromised by 11 p.m. on the 3rd. He can frame it however he wants, but the contemporaneous medical records do not support such a statement.
Okay. Did the records of a deformity, paresthesia, numbness, inability to move his foot, is that evidence of ischemia?
Objection to the incomplete hypothetical.
I'm sorry?
Objection to the incomplete hypothetical.
Again, at the time he leaves the emergency department at 5 p.m. or so, he's moving his toes, his pain is reduced. All of the initial, and a lot of the initial pain of the trauma of his knee injury has begun to resolve with appropriate pain medication. So you keep trying to link a lot of these symptoms to arterial insufficiency when in fact a pulse examination suggests that his pulses were clearly intact. And the subsequent evaluation and operative findings by Dr. Wilkerson clearly suggests that there was no acute ischemia on the 3rd. Otherwise the muscles would have been dead on the 5th.
Well, my question is, Dr. Sarkar testified that there was evidence of signs of ischemia in the medical chart, correct? You remember his testimony?
Yes?
Now, you disagree with that. I understand that.
Yeah.
But do you agree that these symptoms, the following symptoms, are evidence of ischemia? The deformity, okay, inability to move his foot, numbness, paresthesia. Are they signs of ischemia?
Objection. In Mr. Tolson?
Are they signs of ischemia?
Yes.
Without a palpable pulse, yes. With a palpable pulse, no.
Okay.
Especially in the setting of a complex ligamentous injury as we discussed earlier.
So, I understand.
Brian, I have another meeting. I'm just going to make a call. If you, how long, much longer? I'm not, hold, you can do it as long as you want. I don't care. I just want to make a call.
We can take a 5-minute break if you'd like, Bob.
Okay.
Sure.
How long do you think, in case I can tell?
Do you have a...
We're going off the record, the time is 5:11 p.m.